Welcome. My name is Kara McCannual. You'll just get the message that today's meeting is going to be recorded. So my name is Kara McCannual. I'm the clinical manager for the Baycrest BSO program. Today for our behavioral support rounds, we have Dr. David Conn, and he'll be discussing about guidelines for identifying and addressing social isolation and loneliness among older adults. So although we are meeting virtually, we acknowledge that Baycrest and our related Toronto Central Home and Community Care Area behavior support programs operates on the traditional territories of many Indigenous nations, which have been cared for the land of thousands of years, including the Anishinaabe, Haudenosaunee, and Huron-Wendat peoples. And we recognize that currently treaty holders, the Mississaugas of the Credit First Nation, the land remains home to many diverse First Nations, Inuit and Métis people, and is subject to the dish with one spoon wampum, an agreement on to peaceably share and care for the Great Lakes region. We are grateful to have the opportunity to work on this land. You may live and work in different territories, so we encourage you to reflect on the land on which you are located and to consider your relationship to the land and to the people who are the traditional keepers of the land. Just some housekeeping items I would like to just review in advance. So the session is being recorded, as you would have heard, and will be archived on the Ontario CLRI and BSO websites. You can mute and unmute at various times, but if you can hold your questions to the end, that would be great. We'll make sure that we have about 15 minutes of discussion and a wrap up. You can use the chat box at that time as well. So either use the hand emoji or type your questions directly in the chat box at that time. For those of you interested in receiving a certificate of attendance, please enter your name and email address in the completed evaluation form. We have Agnes from Telehealth who will be capturing this all. So I'd like to introduce our speaker or presenter today, Dr. David Conn. So he's Executive Vice President, Baycrest Academy Education, and I'm going to read his bio here. Is a professor in the Department of Psychiatry, University of Toronto, and is a geriatric psychiatrist at Baycrest. He is a founding co-chair of the Canadian Coalition for Seniors Mental Health and past president of the Canadian Academy of Geriatric Psychiatry. So I'm going to stop my screen share and allow for Dr. Conn then to take over. So the floor is yours, Dr. Conn.
Thanks, Kara. Appreciate it very much. And can you see these slides okay?
Yes, we can.
Okay. Okay, great. And it moved, right, when I moved my slide? Yes. Okay, perfect. I was doing one the other day and the slides didn't move for some reason. So even though they seem to move for me. So these are disclosures, really no major conflicts of interest, but just to note I have grant support from a variety of agencies, mostly Canadian federal. And the particular topic we're talking about today is actually funded by a private anonymous foundation. So thank you to the Anonymous Foundation. So learning objectives. So by the end of the presentation, I'm hoping you'll be aware of the association between loneliness and social isolation, poor health, as well as reduced lifespan. Be able to describe the range of potential interventions by healthcare and social service providers to reduce social isolation and loneliness. And to consider the potential benefits and challenges in developing clinical guidelines in this area, and be interested in your thoughts about this later on. So it's a big topic, but I'm going to give an introduction, an overview, talk a little bit about international perspectives, because I think that's interesting, and then specifically talk about this project of creating clinical guidelines for social isolation and loneliness. And this is a project of the Canadian Coalition for Seniors Mental Health. And then we'll have some time at the end to reflect and discuss. So CCSMH, so we're a national organization. We're linked to the Canadian Academy of Geriatric Psychiatry. We are very interprofessional. You can join for free the CCSMH. The website's at the top there. All you have to do is click on Become an Affiliate. No cost, you just end up getting all of our materials, and we'd love to have you as a member. We've been around for 20 years, just celebrated recently our 20th anniversary, which is Great. And probably our biggest claim to fame is developing clinical guidelines. And here's just a few of the recent ones. And you can get all of these from our website. There's an e-learning module that was recently developed on cannabis in older adults. If you're interested, you can also get the link to that from our website. So in the red here, this is the project that I'm going to be talking about today, which is developing guidelines in this area. Just to mention that we do also have a large grant right now from the Public Health Agency of Canada. And you might be interested because our team is working on clinical guidelines for responsive behaviors, the BPSD. And I know as Behavior Support Ontario, this is a critical area. So we're working hard. We have an excellent group that's working group that's working on this. Another group's working on guidelines for anxiety disorders, which we've never had before, as well as doing a variety of knowledge translation for some of our existing work. So I'm going to ask Agnes if she could launch the poll questions. So I'd really appreciate if you'd answer these. There's 3 questions here that you can see. So the first one is, have you personally experienced some degree of social or professional isolation during the pandemic? Yes or no? And the second one is, have you felt lonely for significant periods during this time? Yes or no? And then the last one, for those of you who do clinical work, when you do a new assessment or see a new client, how often do you ask patients specifically about loneliness? And there's 4 options there. We'll give you a minute to answer those. Remember, there's no right or wrong here. It's whatever you feel. Okay, how's it going, Agnes?
We have 75%, 74% participated, right?
Oh, that's not bad. Okay, we'll give you a few more seconds. Then when you're ready, Agnes, you could launch the answers.
Okay, so I'll stop it at 75.
Okay.
And here we go.
Okay, thank you all very much. So 79% say yes to some degree of social or professional isolation, 54% some loneliness, and a variety across the board in terms of how often one specifically asks about loneliness. Thank you so much. It's excellent. And that's very similar, actually. I've asked this, done a number of different rounds where I've asked these same questions, and your answers are very similar to previous groups, professional groups. So, and just to make the point really that, you know, we've all experienced, most of us, almost all of us have experienced some degree of isolation, and many have experienced loneliness during the pandemic. This is an interesting image here from somebody, you know, probably in long-term care, who's trying to connect with another person outside. But this is from Britain, this image, and data showing that there's no doubt there's been dramatic increases in loneliness and since during the pandemic. So when it comes to writing about loneliness in particular, it's often the poets and the artists and writers and songwriters who emphasize this a lot. Now this is from my generation. This is from the Beatles, and they wrote this song, Eleanor Rigby. Some of you might know it, but very evocative, really. Especially the second verse here around Eleanor Rigby died in the church and was buried along with her name. Nobody came. So an image of someone who's isolated, and then on the next, and the image itself, which is from an artist. Her name is Kay Sage, an American surrealist painter, And for me, it's very powerful. I just think, even though you can't see her face at all, just the way it's painted gives you that some sense of someone who's, I think, who's someone who's quite isolated and perhaps lonely. This is more recent. This is from the band Green Day. And here, the verse is somewhat different. So I walk a lonely road, the only one that I have ever known. Don't know where it goes, but it's home to me, and I walk alone. You know, that suggests to me someone who maybe has had a lifelong sense that he is isolated and lonely, but who's more comfortable with it. So Frieda von Reichmann was a German psychiatrist who moved to the United States. And interesting, she wrote about loneliness, and she said that there was a strange reluctance on the part of psychiatrists to seek scientific clarification of the subject, and that it comes about that loneliness is one of the least satisfactorily conceptualized psychological phenomena, not even mentioned in most psychiatric textbooks. And she felt that loneliness seems to be such a painful, frightening experience that people will do practically everything to avoid it. So a lot's been written about this in recent years. There's a lot of focus on it. And I think the pandemic has certainly focused our attention on it a lot more, given that we've all experienced some of it. This is from a paper written by Friedman and Nicole. Amy Friedman is actually a family doctor at Baycrest and St. Mike's, but they wrote a great overview paper where they talked about this topic as being one of the new geriatric giants, and that it's a critical topic in primary care, primary practice. So there is a lot of evidence that there's a strong association. Remember, it's an association between isolation and loneliness and poor health. And here's some of the data in this image here. So really significant increased risk of stroke, of coronary heart disease, of cancer mortality, interestingly, increased risk of developing dementia, increased risk of functional decline, and an increased risk of death, ultimately. So now these are associations, remember that, okay? You can't say that there's a direct cause and effect, but there's a strong association. So this is from the New England Journal of Medicine, just a couple of months ago, and it's written by a couple of individuals, one of whom, Julianne Holt-Lundstad, is one of the gurus in this area of social isolation and loneliness. But they say this is a health issue. And I'll read what they said. They said, social isolation and loneliness are rarely listed on death certificates, yet they may have contributed to the excess deaths from all causes observed during the pandemic. Although the health sector cannot solve this problem alone, the medical community does need to respond. Clinicians will require adequate training, resources, and support to integrate screening, interventions, and referrals into their existing responsibilities. Patients' lives may hang in the balance. Oh, that's pretty strong stuff, isn't it? You know, but certainly it's this kind of work that makes us feel that these guidelines are long overdue. There's a strong association between loneliness and mental health, of course. For example, a strong link to depression. So if you're depressed, you're more likely to be lonely, and the reverse is true as well. Fascinating quote here from the Harvard study of adult development, very long study of adult life. So they wrote that close relationships, more than money or fame, are what keep people happy throughout their lives. Those ties protect people from life's discontents, help to delay mental and physical decline, and are better predictors of long and happy lives than social class, IQ, or even genes. And this finding proved true right across the board, no matter which populations they studied. And from within Canada, there is strong data here that if you report rarely or never being lonely, it's much more likely that you also report much better, excellent or very good mental health. Former US Surgeon General Vivek Murthy wrote that we live in the most technologically connected age in the history of civilization, and yet the rates of loneliness have doubled since the 1980s. This is the increase in the use of various social media over the years. Huge increases, of course, of things like Facebook and YouTube and WhatsApp. Does this make people feel more connected or less connected? Interesting debate. In Britain, they appointed a minister for loneliness. The government felt that this was such a hot issue that their Prime Minister, Theresa May at the time, appointed a minister for loneliness and put money into this. And they have a national campaign to end loneliness in Britain. You'll notice they focus on loneliness, not social isolation, although clearly the two run together, but the campaign itself focuses on loneliness. And there's a lot of great information to be derived from their work. Lots of documents if you're interested in this topic. There's also an international collaborative that's come together, the Global Initiative on Loneliness and Connection, with a lot of different national campaigns coming together to work on this. Canada does not have a national campaign. Here's a couple of really good documents on this topic. The one in the middle is Canadian, and it's from the National Institute of Aging here in Canada. The document on the right is from the National Academies of Sciences, Engineering, and Medicine in the US, and it's a fantastic report, detailed report on this topic, focused on how the healthcare system can help out. And the World Health Organization has also highlighted this as a critical issue in this document, social isolation and loneliness among older people. So it's two different concepts here, isolation and loneliness. They overlap, but they are different. So social isolation is objective. It's a measurable deficiency in the number of social relationships that a person has. Whereas loneliness is purely subjective. It's an unpleasant sensation felt when a person's social relationships are lacking in quality or quantity compared to what they desire. Some have said that there are different types of loneliness. So this is from Hardoon, who says that there's social, emotional, and then existential loneliness. What's existential loneliness? That's an aspect of the human condition which expresses the separateness of the person from others. Different kind of way of looking at it. So they overlap, they intersect, but they don't completely overlap. So some people who may be very isolated are not lonely, and some people may be just the opposite. So it's important to note that there's not 100% overlap here. There's also different ways of looking at social connectedness. So that's the other side of this. So in this case, the idea is that there's structural, functional, and quality. So you can look at the actual structure of a person's relationships, the functions provided in the relationships, and then the quality of the relationship. So just because you have a relationship, that doesn't necessarily mean it's a good thing. It could be a problematic thing. It could be a strained relationship. So what about loneliness across the lifespan? So we're mostly focused here on older adults, of course, in this audience, but it's interesting. I cannot say which group in society has the most loneliness. There's different studies showing different findings, and it's not clear, bottom line. What about internationally? This paper came out in the British Medical Journal last year, and I was really excited when I saw it. I thought, wow, this is great, 113 countries. I'm going to get all the data I want. But they ended up saying that it's very hard to look at the research in this area. There are a lot of gaps. Different places measure it differently. But they did find that there seemed to be a geographic pattern with Northern European countries consistently showing lower levels of loneliness. Surprising. This is from a different source, but it actually shows something similar. So these are rates, these are reported rates from different countries, mostly European. And what you see is that the Mediterranean countries like Greece, Israel, and Italy seem to report higher rates of loneliness, again, subjective loneliness, compared to Northern and Central European countries and the US, which is in there. And I don't know what to make of this. I think it's got something to do with individuals in Mediterranean countries being more open, more willing to share how they feel, more aware perhaps, more connected to their feelings. But it would make a great debate. Interested in your thoughts on that. Now, I know that a significant number of you are working in long-term care. So just a few comments specifically about loneliness in nursing homes. This was from an editorial in the Journal of the American Medical Directors Association a few years ago. And in this editorial, Pit Kalla said that actually this is a critical issue and there's a lot we don't know about it, and it hasn't been well studied in nursing homes. More studied, I think, during the pandemic, of course. The CCSMH and the Canadian Academy of Geriatric Psychiatry wrote a position paper on mental health in long-term care during COVID-19 because of all of the concerns, the obvious concerns that arose during the pandemic. And this got published in the Canadian Geriatrics Journal, but some of the key points here related to the sort of forced isolation that we put individuals into in long-term care to try and prevent COVID and death, but the problems that caused in terms of isolation, loneliness, depression, etc. And really looking to the future, if hopefully it's not going to happen again, but if it does, maybe we will take a different approach, a more balanced approach in the future. And this document highlights the need for mental health care and the rights that people have to get good mental health care in long-term care. Wanted to highlight this document as well. Really excellent document about some of the challenges during the pandemic in relation to person-centered care. And one of the things that's noted in this paper is the Dementia Isolation Toolkit that was put together by Andrea Iaboni and others, which again approached the whole issue of how do we take a balanced approach to caring for people during a pandemic in long-term care, and created a whole toolkit of how a team can work on this. This is from a paper also from JAMDA, Social Connection in Long-Term Care Homes, a scoping review of published research on the mental health impacts and potential strategies during COVID-19. And they looked at all sorts of potential interventions that have been tried to support social connection in long-term care. As you can see, it's quite a diverse group of interventions. They looked at observational studies and then actual interventional studies, and then highlighted in the scoping review which ones found a positive impact on social connection. What you'll see there is that some interesting findings there. For example, managing pain. Now, that's not one of the first things you might think about, but if someone's in chronic pain, they're going to be much less likely to want to interact with others. If you can manage the pain effectively, it seems as though you can have a positive effect on social connection. So all sorts of interventions highlighted here, which I think speaks to the issue that there's a lot of different ways we can help this problem. Pets and even robotic pets have been used with some positive outcomes, interestingly. Also highlighting the fact that other populations are at higher risk for social isolation and loneliness, as you'll see in this slide. So marginalized US communities, this is from the US, immigrants are at higher risk. And of course, marginalized groups face health and healthcare inequities that are critical to understand. So And there's similar data from Canada as well, very much so, including First Nations, Inuit and Métis communities. Lots of reasons why older adults were at increased risk of experiencing social isolation, as you can see listed here. If you think about long-term care as well, dementia itself is obviously a risk factor, and the challenges that individuals with dementia face in terms of communication and the potential for isolation. Now, why is it that there's this association between poor health and social isolation and loneliness? And this image tries to explain some of it, and it suggests that some of it may be related to lifestyle, some of it may be related to actual medical adherence, to whether people who are socially isolated are actually less likely to go along with taking medications or executing positive lifestyle changes. But then also a suggestion that there may be a biological effect. So it could be, and so one of my colleagues just sent a paper today on the effects of inflammation associated with social isolation and loneliness. There's quite a bit of good basic research now, basic science research, suggesting that there's a strong association with various biomarkers like inflammation that in the long run may cause illness directly. So a lot we don't understand, but some theories at least into why there's these strong associations. So let me move now to the origins of the actual project that we're working on. As I mentioned, it's a private foundation that's supporting it. This foundation does work in a variety of areas, including working with older adults, supporting older adults. And they contacted us and said, you know, we think that we might want to support you in some work. And we talked to them, and they were really interested in this area of social isolation and loneliness, and funded some other projects in this area. And you know, after a lot of discussion, given our experience with guidelines, they decided to fund us to actually develop these guidelines. It's a 2-year project, and we're almost halfway through. So yes, this is a major opportunity here for all of us, I would say, not just those in primary care, but right across the healthcare system to help. So we've done a lit review. We put together a guidelines working group with some expert reviewers. We've done one of 2 national surveys. So we've recently surveyed health and social service providers to get their opinions and views on this topic. And we're soon to embark on a second survey of older adults and caregivers with lived experience. In the long run, we're going to finish these guidelines and disseminate them, as well as creating toolkits, knowledge translation, and raising the issue is a big part of this project as well. Strengthening the network. A lot of individuals are interested and working in this topic. A lot of organizations are. How do we bring everyone together? This is the working group. Some really excellent people here with a variety of different backgrounds from different parts of the country. So it's pan-Canadian. Got our excellent CCSMH staff as well. Betty Watson-Borg, our project manager, I saw is online with us today. So welcome, Betty. And we have one other member, Lisa, who's joined the team as well recently. So why create clinical guidelines? This is clinical guidelines in general. Well, there's certainly data to suggest that they can improve the quality and consistency of care, improve outcomes, empower patients to make more informed healthcare choices, even inform public policy, and call attention to under-recognized health problems, prevention and interventions, as well as to neglected patient populations and high-risk groups. It can also identify research gaps. Like any intervention, though, you have to watch out for potential harms. So a clinical guideline, for example, that gives you the wrong advice could be dangerous. They tend to be utopian and to be highly focused on a single problem, whereas we know in working with older adults, it's very rare to have an older adult with a single problem. So how does one set of guidelines interact with other guidelines? We have to be aware of that. When you create guidelines as a recognized process, and here's the general way of doing it. So you create questions, you look at the evidence, you try to put it all together, you develop recommendations and determine their strength, and then you have them reviewed and you go back and forth, eventually try to get them right, have them reviewed, and then ultimately, once you're satisfied that they're useful, you disseminate and try to implement the guidelines or support people to implement them. So we are certainly developing evidence-based guidelines as much as is possible, although when we look at the research in this area, there are a lot of gaps. We hope to develop a guideline that's manageable and offers a stepped care approach. In other words, you can start with maybe small interventions and then increase as needed. A broad range of approaches considering a diversity of service professions and older adults, and also guidance promoting wellness and reducing the risk of social isolation and loneliness, so a prevention section, and then targeted messaging and knowledge translation. Normally, when you're doing a guideline, you look at existing guidelines and then you evaluate them. How old are they? Were they good? Can we use parts of them? But we couldn't find any existing clinical guidelines on this topic. The document I mentioned from the US earlier, from the National Academies, does have a few recommendations. It's not a guideline, it's a report, but we are looking at that report. And this is perhaps the most relevant section here. So they actually suggest, this is their recommendation, and it was a very esteemed committee that put this together. They said that healthcare providers and practices should periodically perform an assessment using one or more validated tools to identify older adults experiencing social isolation and loneliness, and to initiate potential preventative interventions after having identified individuals at elevated risk due to life events. And then they say if you do identify individuals who are currently isolated or lonely, that we should discuss the adverse health outcomes associated with this. So educate. And then we should attempt to determine if there are causes or things that are contributing to it, and then try to address those causes. So we did do a literature and promising practices reviews. Linda Horgan and Jeanette Burrock are research consultants who are working with us on the project. So they helped us do this. We looked at 4 areas. These are the 4 areas. So practice interventions, patient experience, promising practices, and screening and assessment tools. Whole variety of interventions listed there on the left that you can see. We looked at a whole variety of reviews of these interventions, and there are quite a few out there. And after looking at all of the evidence, we suggest that there's no conclusive recommendation that could be made for one intervention over another, not surprisingly. The ones that seem most likely to produce positive outcomes incorporate multimodal, group, and peer components. So, it depends on the individual. Obviously, we're not going to say that there's one best intervention. You really have to understand the person you're working with. When it comes to promising practices, so this is sometimes what's called the grey literature. Let's say from the United Kingdom, the work they've done on social, on ending loneliness. We found some useful material here. The recommendations highlight patient-centered care, collaborative health and social care, bringing the 2 together, tailored services for diverse populations, and the use of technology in appropriate circumstances. There are a fair number of screening and assessment tools out there. There's and there's short ones and long ones. About 10 of the 15 that we found have been validated with older adult populations. This document, the NASM document, actually looks at all of them and gives detailed information on how they vary and what you're actually measuring with them. The simplest one that's used quite a lot is a 3-item loneliness scale, as you can see here. So that's sort of practical and, you know, one that you could imagine using in clinical practice. I think short screening tools are obviously advantageous. This is a longer one, a social network index, but I do like parts of it. The items in red here are really interesting questions, and I think helpful if you're really wanting to understand a person. So is there someone available to you whom you can count on to listen to you when you need to talk, or someone to give you good advice? Or is there someone who shows you love and affection? So, you know, these are the kind of questions that would really get at how a person is viewing this and their experiences. When it comes to patient experience studies, there's not a lot out there, but some of the barriers identified include difficulty locating and accessing appropriate services and lack of personally meaningful and culturally appropriate intervention activities. And so, you know, after looking at all the literature, we find that there are challenges and limitations. One being is isolation and loneliness treated as a singular or a distinct concept or overlapping? And, you know, so we need to know which of these things has been looked at in various studies. Different methodological inconsistencies, as we often find, and really a lack of research regarding the impact on diverse populations. And that's something we really want to try and find out more about. And very few patient experience studies. So when it comes to interventions, you know, you can look at the different levels. So who's actually empowered? Who can make changes? With our guidelines, we're focusing, of course, primarily on health service and social service practitioners, providers. So that's the sort of the middle group in the, you know, but some of the interventions need to take place at higher levels with government and health authorities and funding bodies and so on. With our guidelines, we're hoping that we might be able to influence some of these bodies to do more in this area. Like, I would love to see a national campaign here in Canada, just like the United Kingdom has. That would require, I think, a concerted effort from a high levels of government. This is from a chapter in a book on loneliness. It was on one of my earlier slides, recently published by the American Psychiatric Association Press. And the authors here tried to say, well, okay, what's the main driver for the loneliness? Is it a mental disorder, a physical illness, a social stressor, a functional impairment in general? And perhaps we need to take those into account when we're intervening. And they suggest that there's a variety of different interventions that might make a difference, but that we might be able to tailor the interventions depending on what are the causal factors. This is coming back to that article from the New England Journal of Medicine recently. The authors here come up with what's a fairly simple framework that they suggest called EAR, Educate, Assess, and Respond. So the first part here is educating and making sure people understand that, that there's a significant effect on overall health. And of course, helping patients to maintain their health and manage existing medical conditions through social connections. So just emphasizing the benefits of social connection. And then in the individual, assessing, so documenting, specifically in the health record, identifying patients at risk with validated measures, and then tracking risk and progress. And then of course, responding. So reinforcing the need for social connection, integrating psychosocial supports through all members of the healthcare team, including volunteers and family, making referrals to the community. Now, one thing I haven't highlighted yet is something called social prescribing, which is one of the key interventions that's being used a lot now. Social prescribing is helping to connect a patient, a client, to community resources, often through specialists in this area. So individuals who are knowledgeable about what's available in each community and can help a person to get connected to those. So finally, this is back to the World Health Organization. So they say globally, we need to create a coalition. We need to improve research and evidence for what actually works and to scale up effective interventions. Good advice. I'm going to stop there and open it up. That's my email address if you want to connect with me at all. I've got Betty's email there as well, who's our project manager, and I'm sure she'd welcome any thoughts, ideas that you have. And there's our website at the bottom to get resources. And going to open it up for your comments, ideas, questions, any thoughts you have about this project, about guidelines. Are they, do you think it's a useful project? Do you think it's something that we can work on together?
Thank you so much, Dr. Conn. I can just taking a look at the chat box. So there was an earlier comment saying from Callie, hopefully I'm pronouncing it correctly, I'm of Greek descent. I suspect that because a lot of elderly continue to live in villages or small towns, may report an increased level of loneliness than those in other countries, meaning that they are not living close to their families who live in cities, because that is, sorry, I'm scrolling down, where they work, go to school, etc. Obviously not a generalization, but a thought. So just their 2 cents there. Another comment or question rather from the chat box, can you recommend any valid social isolation tools appropriate for long-term care?
Yeah, so that's a great question. I have not seen any tools that have been specifically developed for long-term care. But I think the ones that are available could certainly serve the purpose. So happy to share that. We can be happy to share with you the ones that we have discovered in our work so far. I think the most important thing, of course, is to actually assess someone's degree of connectedness and isolation. And when it comes to loneliness, you have to actually ask someone if they feel lonely. And I think we often forget to do that. We make assumptions. And if you don't actually ask and really delve a little bit into what a person feels about it, then we should not make assumptions.
Thank you. So some questions. Dr. Cohen, go ahead.
Hi, David. Thanks so much. So interesting.
Yeah.
Not a question so much as a reflection. I noticed on a news piece recently that there was a lot of social connectedness in England because everyone was meeting together in warming centers. So I'm not suggesting that we make all our patients suffer, but it seemed to me it's so interesting that we can prescribe when we can diagnose, but times of adversity and need brought people together who now come together weekly to do things together and are creating a community. So I just thinking and reflecting on how we create community without prescribing, which is sometimes, people don't want to necessarily hear that we're prescribing something, but how do we create community in a way that's more acceptable?
Yeah, I think that's a great point. And I think that's a very important point. And just to emphasize that, people vary so much in what they want and what they believe. And for us to simply say, well, everyone should be socially connected, it's a really good thing for everybody, is I think, a mistake. And we have to, there's a whole range of feelings about this. That image, the Green Day, that guy who walks alone, but he's quite comfortable walking alone, to me we have to remember that individual. And there's been some questions raised about really an ethical question, and that is, could we actually do harm by asking everybody, how socially connected and lonely they are, with the assumption that if if they say that they're lonely or not connected, that somehow there's something wrong with them. That. So I think we have to be a little cautious around this, and certainly not over medicalize this, even though there's a strong association, very strong association. I do think we have to consider everyone's unique perspective.
In the chat box, Gloria, sorry to interrupt, just said agreed. The word prescribing can be problematic.
Yeah, Gloria, interesting. Did you want to say something about that? I think that's a really interesting that you would comment on that.
Sure. I mean, I just noticed in what you just said as well, the thought of over medicalizing and sort of having a really scientific, quantitative, medical co-opting of arts and culture and community is like some of the last untouched realms of that have their own benefits without needing to be sort of authorized by the medical community.
Right. Yes. It's very interesting you should say that, because that term prescribing does make us think about the prescription pad, right, or a drug, right? So I mean, I think it's meant to say to healthcare professionals that there's a lot we can do that's not drugs, right, and that we should prescribe those things to get away from that. And but at the same time, it does sound rather medical, doesn't it? Social prescribing. But I haven't actually heard much criticism in the field about that term, but it's interesting that you would say that.
Callie, go ahead.
Hi, thank you so much. I did have a question, actually. It came up when you mentioned inflammation being a part of, it was having a relationship with, I think it was isolation, social isolation, and or with reported loneliness. I'm wondering what the research is showing in terms of addressing, like, when you're talking about like sympathetic nervous system stuff. I know I'm talking a little bit more like maybe biological factors as well, but I mean, when you're looking at like elderly populations, like looking at like their life histories and stuff, like, and you're looking at this as well from like a trauma informed lens, looking at like circumstances that they've grown up with, maybe estranged from families over a very long period of time and such. So I'm just wondering if you came across any of that to see if that might help inform some interventions.
Yeah, so I think you're talking about individuals who've perhaps suffering from post-traumatic stress, who've had lifelong histories perhaps of trauma, and the impact then physically, as well as the likelihood then perhaps that they may become more socially isolated. And there's a lot of evidence that, for example, people who suffer from post-traumatic stress disorder, that there are impacts on the brain biologically, increased shrinkage of the hippocampus, for example, which is critical brain structure for memory, and an increased risk then of dementia. So I think, that's just one example, but I agree with you that there are probably a lot of different biological explanations, and it's highly complex. But and some individuals who are more isolated and lonely, may have had very difficult early lives. Not all by any means, but some. So absolutely.
There's a lot of activity in the chat box, some links being shared. A shout out to recreational therapists. It's been an excellent resource, and compliments to you, Dr. Conn, on your presentation. Yanti said body doubling or parallel working is a phenomenon on TikTok. So it's that app that the youngsters are using, wildly popular with remote workers experiencing isolation and loneliness. Yanti, can you please expand on that? Because not everyone is familiar in terms of that terminology, body doubling, and not everyone knows about TikTok. So would love you to expand.
I'd love to hear about that. I'd love to hear about it.
Hi. Okay. I'm sorry. I signed it from my cell phone. Excuse the picture. I don't know if it's still there of my children.
That's great.
It's just something that I read about. If you want, I can maybe send someone the link. I mean, I find I'm new here at Baycrest and everyone's in their little pigeonhole. I'm used to a school environment where it's more interactive. And then I stumbled on this article, which was very interesting, how this one person was working remotely and he just felt kind of isolated and lonely, especially if someone has ADHD. They kind of need that stimulation of people around them. And he just posted himself and he got so many views and it became a phenomenon where people are just kind of like posting themselves, sort of working online to feel like they're part of a community.
Right, right. You hit on a really important issue there. I think that is the hybrid working environments and the challenges of it. Some people love it and the flexibility of it, but those of us who've engaged in it realize that you don't feel as connected to your colleagues, right? And so some people, you're saying, have used social media to try to forge a sense of connectivity, which comes back to that slide I put up earlier, sort of provocatively saying, you know, massive increases in social media in recent years, and does that make people feel more connected? And I think there may be a generational thing there as well. I think younger people feel that they are highly connected through having lots of friends online and so on. What do you think? Do you think it's it actually forges increased connectivity using online, social media, etc.? It's a reflective question for all of us to think about.
Maria, I see you have your hand up. Go ahead.
Yes, I have a question regarding if you know anything about funding, because you know, when we're talking about social prescribing, you know, when I learned about it, from what I remember, when they say social prescribing, it was the idea. So if you prescribe, you know, going to this exercise class or whatever, then it will be like covered by whatever government it's covered from, right? Like that's like, I don't know why that is staying in my mind, all right? So that's why I thought it was a positive thing, right? So I don't know if nowadays, again, is there, you know, from whatever provincial, federal government, any funding specifically for, again, more social things for older adults that are not really, because I know we know the community centers and all this stuff, but you know, that's what I see a lot, that you know, clients do want to socialize or participate in activities, but unfortunately, due to financial constraints, the reality is that they can't. So it's either they buy food or they you know, they attend a social program. So I don't know if you know of anything in regards to funding for this specific topic.
Right, so there's two aspects to that. One is the sort of process of social prescribing itself, which requires resources. So you have to have those individuals who are being funded as links between the person and the community resources. So they are experts in the field, but you need those individuals to be hired for that job, and that's resources. So there has been some increased funding for social prescribing in Ontario. It mostly started out in the United Kingdom, but various jurisdictions are now trying to fund this as a good model. But then, as you say, you may be able to connect people to various programs and activities in the community, but do they have the financial resources to actually make use of them? And that varies a lot. And so, so financial challenges can be a factor too. I mean, if you don't have any extra money, you know, it's very hard to actually connect with other people. In some ways, maybe you have enough to go out for a coffee, perhaps with someone. There are things that you can do that are not expensive, but you're right that the financial side of this is very important, and challenges in finances can be a factor in increasing social isolation for sure. There are a lot of community resources out there and community programs, so that the whole idea is trying to find a good fit between the person and what's out there, and taking into account, of course, their financial situation. So thank you for that comment.
Great. Some more comments in the chat box. So Judy earlier had said that sometimes prescribing it gives it some importance and people take it more seriously. Uma said, I also feel someone could be socially connected and yet be lonely, since loneliness could be a state of mind and could go unaddressed. Marlene said, social media can possibly increase feelings of loneliness when one is watching others posts of attending activities and parties in different places. They feel left out and feel isolated from other people.
Yeah, good point. Yeah, and I think, I mean, we're talking mostly about older adults, but the challenge for younger adults too is quite significant, and particularly highlighted during the pandemic. There are lots of apps now that, the original apps, of course, to get where people are looking for a partner, or you know, but there's quite a few out there right now that are simply, if you want a friend, you know, let's connect.
Marilyn.
Yeah.
Hi, great presentation, David. Really looking forward to seeing the guidelines. Wondering if there's a way, if you'll be addressing special subpopulations like people with addictions, you know, people with substance use disorders, because that's so common in this population, and people with mental health issues. And so that's one question. The other one is, as a comment that I put in the question, I thought that Tim Hortons should be the ambassador, and they should have social isolation sort of clubs to help seniors, and just offer up sort of, you know, Thursdays as a seniors you know, free coffee day or something like that, because a lot of rural doctors will say, you know, it'd be great if I could just have a clinic at Tim Hortons.
I totally agree with you. Yeah. And in response to your first question, I think our subgroup that's looking at interventions is trying to look at subpopulations and what the evidence is. So I'll let you know. I'm not sure yet how far they're getting in terms of specific interventions for specific subpopulations, and that equally applies, as I said earlier, to the diverse populations right across the country. And someone mentioned, of course, rural versus urban as a critical issue as well. So we're trying to look at all these things, but based on the evidence. So.
Oh, I saw that there's a lot of research on youth addictions and isolation, and there's just a little bit on older adults and isolation, but it's there in the research for sure.
You can write it. That will be your next project, Marilyn. More research. So we're almost at time. Dr. Cohen wrote in the chat box, thanks so much for keeping us up to date on this important work.
Oh, thanks, Karen.
Any other last minute questions?
Well, thank you all so much for your active participation. I really appreciate it. And stay connected and join CCSMH, okay?
Thank you, Dr. Conn, for a wonderful presentation. Just a quick reminder that if you would like a certificate of attendance, please complete the brief evaluation survey. It will be emailed to you. The recording will be available on the Ontario CLRI and BSO websites. Thank you again for everyone joining us. Have a wonderful day. And there are a number of ways also, I'll just click to the next slide here, to connect with CLRI, take a look through. You can follow them on social media, Twitter, Facebook, LinkedIn, sign up to receive updates through our newsletter as well. Thank you very much, everyone. Have a great day. Thanks again, Dr. Conn. Such a great session, very informative.
Well, thanks, everyone. Bye.